Welcome to this session on buprenorphine starts for patients using fentanyl. We have Dr. Reb Close from the Monterey County Safe Prescribe Initiative. And so we'll go ahead and get started here in a minute. So Dr. Close is an attending emergency physician at Community Hospital of the Monterey Peninsula and the lead clinical physician for the Monterey County Prescribe Safe Initiative. The Monterey County Prescribe Safe Initiative is a collaborative effort in Monterey County to promote the safe use of prescription drugs, promote safe pain management, reduce overdoses, and address substance use through preventative efforts and treatment. She's been a regional director for California Bridge to Treatment program since 2019. Dr. Close attended medical school at UCLA, completed residency in emergency medicine at UCLA Olive View Medical Center in Los Angeles, and is board eligible in addiction medicine. She has been on staff at Community Hospital of the Monterey Peninsula since 2003. So welcome, Dr. Close.
Thank you. Thank you so much. Yeah, I'm really grateful to be here today. And if anybody's heard me speak before, I tend to be pretty animated, but this really fires me up because you're going to get to hear me talk about my patients that I take care of in our street clinic. And you're going to get to hear how we really get them safe and get them to care. And they're in a bad state and we can do something about it. And so I get really fired up about this topic. So let's get started. So I'll give you my background as we get to the next couple of slides. I have nothing to disclose, except I'm crazy passionate about this. That's about it. And then please remember National Recovery Month. This is where some of the greatest outreach we get to do in embracing our community. And so I'm really grateful that we have this as part of the slides. Okay. So we're going to talk about bup starts for patients using fentanyl. And this is basically every patient I take care of. And so this comes from my personal experience. I'll share with you what is California Bridge guidelines, what is literally what I learn on the ground with my patients. I am an ER doc. I'm emergency medicine trained, so you're going to hear that in my personality. Second part is, though, I actually stepped out of the ER to do addiction full time. This is where my heart is. After 20 years in the ER, I need to do something to make things better for this group of patients. And I'm very grateful for that. I'm sitting for my boards next month. And then we came together as a community about 10 years ago and made the Monterey County Prescribe Safe Initiative. It's actually grown to a quad county initiative, and we're really trying to push the envelope on how we get our patients connected to care. And part of that is through my work with California Bridge, where I'm a regional director. And it just makes it so you get these crazy passionate people who are ridiculously overly smart. You put them together with a common goal. And it's been really fun. And everything the Bridge does truly is about giving. So all the resources, everything that you'll see me reference is on the Bridge website and is available for use all the time. That's kind of our philosophy. I do need to give credit. The Bridge helped me with the slides because I graphic zero. I have no skills. And Dr. Alicia Gonzalez, and when I said wicked smart and amazingly brilliant people, she's one of them. And so we feed off of all the energy in the Bridge team to really figure out what we can do to impact our communities in a positive way. And so thank you, Dr. Alicia Gonzalez. Some of the slides she helped me with, and we worked together on all this stuff. So kudos to my team. All right. As I mentioned, nothing to disclose. I do tend to kind of go back and forth with brand names and generics. So if there's a question, please stop me, and I apologize for that in advance. Okay, so thank you to Dr. Coffin for a lot of the information on fentanyl to keep everybody. I wanted to make sure everybody was on the same playing field with why is this here, what's going on, and why is it so different? So I'll go a lot quicker than I was anticipating through some of that stuff. So please stop me. It took me a while when we were trying to figure out what was going on with fentanyl to wrap my head around it. Why? Why would you kill the people you're trying to have as, purchase drugs from you? And I have a handle on it at this point. And so we'll talk about that. But so I'm going to tip into the current situation on fentanyl, knowing this group obviously has a lot of background information, but this is a to and fro, please. But really why we're here is to understand how to start bup for your patients that are on fentanyl. I mean, people are scared to death of this on both sides. And so we need to talk about it and normalize it and partner in it. And so we're going to go through that in detail. And then really understanding and addressing the patient needs before the start, during the start, and after the start. All right, so let's run through this. And I tend to, oh, one of them didn't make it on the slide. I use a lot of acronyms, and I apologize in advance. So SUD, everybody knows. OUD, everybody knows. MAT, and I use MOUD, and that's the one that for whatever reason got cut off my slide. I say MOUD a lot. I find that to be the least stigmatizing term that I can use right now. Everything in medicine changes all the time, but that's what I'm using today. And so that's usually that will be what you hear me use the most. Okay. All right. And just so, again, we're all on the same page talking about our drug use. And I use these terms with my patients as part of my partnership, right? Okay. So we talk about tolerance. So if you have regular drug use, your body becomes used to having these substances around. And in order to feel normal, your receptors and the sensitivity of them changes to keep you in a steady state, right? With that external drug, right? That's your new steady state. And so there's a tolerance that builds up to get more effect. And then also that leads into the withdrawal. When that drug's gone, now you're in that low state, right? Because you were steady with the external drug. Dependence is really important. And I use this with my patients. My father-in-law was a cancer patient, and he was on methadone and he was on oxys and all kinds of stuff. And he was 100% dependent on those drugs, 100%. Right? His body had changed itself enough to realize that if I have the drugs in my system, I'm okay, right? If we had taken those drugs away from him, he would have gone into florid and horrible withdrawal. That's different than how we define addiction, which is the behaviors or the activities of either crushing and snorting your oxy, or going to various locations to get different or other drugs, or injecting. Those things are more of the addictive behaviors. And I talk to my patients about this. We talk about, I'm like, absolutely your body's dependent on fentanyl, 100%. And I talk to them about my father-in-law, right? And so just realizing when you use that language with your patients, it helps give them the common ground that you understand the physiology of what their body's feeling. And so you can empower them to kind of take actions in ways that feel okay in their own bodies, okay? So we're going to talk about that. And then, as my last lecture was really serious about, which is on stigma. If I use a stigmatizing term, I ask you to call me out on it. I have changed my language so dramatically in the last 5 years because it's so important. And so words such as, I mean, literally, I was going to buy a shirt, fight addiction, not addicts. And I couldn't have addicts on my shirt. I couldn't do it. And so I really am asking, we need to consider our language, and that goes for me always. All right. This group is very well aware that SUD, substance use disorder, is a treatable brain disease, okay? So just like my patients with crazy blood pressure, I talk to them about blood pressure medications. It's the same thing. For my patients with opiate use disorder, I need to talk to them about treatment for opiate use disorder. My asthmatics, we talk about inhalers, right? This needs to be in that same thought process. And I tell my patients that, right? Because yesterday I had a patient say to me, oh, I don't want to trade one drug for another. And I said, well, okay, totally understand. I understand that. But if you had high blood pressure, I would ask you to take a medicine to help control that. And maybe with diet and exercise and all these things, you could bring your blood pressure down, but that's not today. And right now we do need some help for that. And that's how I discuss it with my patients, is to try to help them understand that this is how I'm looking at it. Bear with me, and please consider looking at it in the same way. This is a chronic disease and we'll get you through it. Let's talk about, if you want to get off medications later, that's great. Whatever you need is the right answer. Let's do today. Let's do right now. Okay. All right. So the thought process that addiction is a moral failing has to go away. And that's our job. And as I see it, as leaders, as people that connect with healthcare teammates, as well as all of our patients and their families, this moral failing business has got to end. And I think we're on that. Okay. So I'm going to breeze through the fentanyl stuff, as I mentioned. One thing, though, that I didn't really put in my slides, as I just wanted to more talk about it, is that whole thought process. When fentanyl came to my community, we had no idea what we were up against, none whatsoever. So we started seeing a smattering of overdoses that made no sense. And the docs would call me, because I do this, right? I'm this passionate about this work. And the docs would call me like, dude, something's wrong. I don't get it, right? The patient said they just took half a Percocet and literally he was down. He was so down. It was multiple rounds of Narcan. We put him on a Narcan drip. Something's wrong. Well, we had no testing to prove anything, but we knew something was happening. And it was finally when my community lost a 16-year-old girl to a fatal overdose, or a poisoning, as I call it, that we got the post report and confirmed fentanyl in my community. Okay, so in the beginning, we had no clue, and I was trying to figure it out. Why in the world, if I'm a dealer, why would I give a drug to someone that was potentially going to kill them? You know, I'm not a businessman, right? I went to medical school. I'm not a businessman. I don't understand business at all. But like, killing your clients didn't make sense to me, right? But there's so much more to it with fentanyl. So we're going to hit some of that, and then we'll summarize it up before we jump out of this and into buprenorphine. So obviously, you guys know opioids and opiate, right? Then the all mu receptor painkiller opioid related drugs, and then opiates are the natural. All cause euphoria, sleepiness, that slowed breathing and mentation that Dr. Coffin talked about. Everybody's seen this graph at this point, and I think this is one of the ones that he showed today, showing how that happened. And it's right here. October 2019 is when we confirmed Fent in my community. And I went back and found the Fent in the Coke and the Fent in the cannabis. And I was like, hey, wait a minute. Oh my gosh, it was here before we knew. But we didn't. We totally didn't know. But we were seeing it as well, and it's taken over in my community as well. And again, everybody knows the changes, so I'm going to breeze through this. Interestingly, looking through, if we break down the data by demographic, initially we were seeing that the overdoses were more in the non-Hispanic whites. And this goes back to stigma, as I talked about earlier today, and a lot of our racial disparities. Because initially the prescriptions, when we started this opiate epidemic as clinicians, they were to non-Hispanic whites. Unfortunately, what we're also seeing now, and this is unfortunate across the board for everyone, is that we're starting to see an increase, disproportionate impact in our deaths among our Black and African American population. And so when I think about naming someone who has a friend with addiction, who has lost someone to overdose, who themselves has suffered with a use disorder, you know, if we think about it, can you name someone? And then I challenge my patients or my friends and my family, tell me someone who hasn't. You find me someone who isn't touched some way by a use disorder. All right, so kind of bring it home, of course, we all can. Every one of us has kind of personal experience, personal connection with someone who is suffering in this regard. Okay, so this is Dr. Gonzalez. What the fentanyl, right? I love her, by the way, Dr. Gonzalez, she's so cute. But seriously, WTF, what the fentanyl? Like, why is this happening? That's what I said, you know, if I'm a businessman, killing my clients doesn't make sense. So first of all, if you're growing opium in a field, right, you have weather to deal with, you have water to deal with, you have cultivation to deal with, and then you have transport. That's expensive and a waste of time and money, right? If you're making fentanyl, it's a couple of chemicals, it's a little bit here, you've got your magic bullet, I think they're what, $39.95 or something at this point, to mix your pills, pill presses you buy on Amazon, like dirt freaking cheap, okay? So it's laboratory designed. You don't have to do crops. You don't have to transport kilos of heroin, right? Because it is so much stronger, you can transport it in tiny little packets. It's small enough that you can put it in the mail. Like, it's literally that simple. No more do you have to have the mules with, you know, the heroin taped to their bodies and all this stuff. It's a waste of time and money. So unfortunately, it's market, right? It's a money thing. The fentanyl itself has so much higher receptor affinity. So I do this every day in my clinic. I feel so bad when my patients see my little hand. But so my opiate receptor, right? And you can activate it, right? Fentanyl binds so tightly and activates it so effectively, you need far less to get the same or a greater effect, okay? This is what just was so hard for us to wrap our heads around initially, is it doesn't show up on a tox screen. I cannot tell you how many times my docs would say, they're not using fentanyl, the opiates are negative in the urine. Fentanyl doesn't show up on an opiate screen, guys, by the way, unless you do a specialized test. My own lab, I don't know if fight is a good word, but kind of, to say, look, we have to test for fentanyl. It's really interesting because as we know, opiate overdoses or poisonings, right? They're not subtle for the most part, but the reality is how many of my patients don't have any idea whatsoever that they're using fentanyl. Because in my community, if you're using meth, you're using fent. If you're using cannabis from the street, you're using fent in my community. Like 100%. If a Xanax bar, come on. It's all fent in my community, right? The blues, really, those are all fent in my community. So basically anything you off the street in my community is fent, right? But the patients, it's crazy. So when you take a patient and you talk to them about their meth, or you talk about whatever it is they're using, and you say, well, what about fentanyl? Oh, no, I don't use fent. And you show them the urinalysis that says fentanyl positive, that conversation is open. Versus the I don't use fent to the there's fent in my meth? I'm sorry, right? And that's a part of my conversation to say, any day that I have buprenorphine in your system, you are less likely to die from the meth on my street. And that partnership is a big part of what I do with my patients. So we talked about why fentanyl, right? It's money. It's super easy to transport. This is easy. It's unfortunately a dollar's game. And if I'm selling this, if I kill a few people in the process, the money is like this. So unfortunately, this is market, and heartbreaking as I can, it's so heartbreaking to believe that. What's so weird about fent? And I've been using it in my practice since I was a medical student, right? Like this has been around forever, and we love it in the ER as a actual pharmaceutical agent because it's quick on, quick off. Right? I can literally, if you come in with a kidney stone, I can give you fentanyl. And then by the time you're ready to go home, it's metabolized. Like we're good. Okay. So we love it in that regard. The issue is, and what we're finding is that as you use it regularly, it builds up in the fat stores. And so instead of being quick on, quick off, it's quick on, quick off. Ooh, but there's still some left. Quick on, quick off. Ooh, still a little more. And it builds up. And so what I tell my patients, you have like a sink of fentanyl in your body and it's leaching out, and that's why it makes starting buprenorphine more challenging, not impossible, not by any means. And I'll give you a lot of information about what I do in the street, but that's how I explain it, is that you get this big fentanyl sink in your body and it kind of leaks out. And so it's not enough to keep you out of withdrawal. And it's not enough to feel any good feeling from it, but it's there to interfere with us trying to get you safe. And that's my candid way of talking to my patients about it. Okay, so I already mentioned this. Oh, I forgot to mention my heroin covered in fentanyl. It's ridiculous. The pills on our street, we just had 65,000, I think, that were seized. This isn't data on the drugs in my community. This is DEA information. But 42% of the pills that they tested had what would be considered a lethal dose of fentanyl in them. And my patients, so it was crazy. It was about a year and a half ago, we had 4 people come in and they had taken a blue and they had quartered it, okay? One person had a near fatal overdose. Thank goodness somebody close by had Narcan. 2 people had some of the desired effect and someone got nothing. And that goes back to that magic bullet thing, right? This isn't pharmaceutical grade medication creation, right? This is put in the magic bullet, throw it in the pill press, ready to go. More pills, let's go, right? And so I tell my patients, and this goes for fentanyl test strips, which we'll talk about, if you shave off a piece of your pill, Did you shave off the piece with the fent when you're testing, or did you miss that piece and all the fents and the rest of it? So yes, I absolutely, I pass out fentanyl test strips on our street clinic all the time, 100%. But I talk to my patients about it and I educate them about it, because these, and I describe the pills as chocolate chip cookies. You actually don't know where the chips are, right? I know, I told you I get super passionate and a little weird about this, but you don't know where the chips are. And that's what I tell them. So you don't know where the fentanyl is in that pill. Okay. But when they test them, the DEA tests them, about 42% have what would be a lethal dose. Now, back to that tolerance thing I mentioned a while ago, right? I have patients, I have a gentleman right now that has been taking 10 to 12 blues every day. So he has to use every couple of hours. He'll use a half or one, just depending on how he's feeling, every day to stay out of withdrawal. His tolerance is insane, right? And that's going to come back to when we're talking about how we're going to do some buprenorphine. Okay. And then just keeping in mind that trafficking is by the kilo. And when I dose fentanyl, if you come in my ER with a kidney stone and I need to give you fentanyl, I'm going to do 50 micrograms, maybe 25 if you're little, maybe 100. You just kind of, there's a lot more art in medicine than science some days. But if you think we're talking micrograms is an appropriate dose for a kidney stone, right, a very painful condition, they're bringing it by the kilo. So you can see why we're having so many fatalities. Okay. All right. So all that stuff I just talked about with fentanyl, that's why there's been a lot of concern about, well, how do I start buprenorphine and how do I get patients on MOUD? And what if I precipitate withdrawal and what happens with Narcan? Right? So we're going to go through all of these in some form or fashion. And the kicker is it works. And how do I know it works? Because I do this on the street with my patients. I don't have vitals. They don't have running water. They don't have access to toilets. Okay? I do this with my street patients all the time. Every street clinic, I'm starting someone new on buprenorphine. I'm talking to them about how to do it. And then they follow up with me and we talk about how it went. Okay. And thank you is the word I hear the most. So we'll keep going. All right. Oops, wrong button. Okay. So I mentioned we're going to talk about fentanyl. We've covered that. Now we're going to go through the nuts and bolts of buprenorphine treatment in patients with fentanyl use disorder, and combining that with what do I do before, during, and after the induction. All right, so this is another Dr. Gonzalez, because she's still super cute. Keep calm and start bupe. That's the plan. All right, and just some information on the California Bridge program is low barrier treatment. Going to the patients on the street and starting them on buprenorphine that minute, that's about as low barrier as you can get. Patients ask me all the time, do you need my insurance card? I'm like, oh, don't care. Not interested. As long as you have, as we have a way to get you this medication that, you know what I mean? Because obviously they have to go to a pharmacy. So as low barrier as possible. Treatment for substance use disorder does not end with a medication. And so it's that connection to treatment, connection to care, and community. So literally in our little pup tent kind of thing with our foldable chairs that fall in gopher holes, out on the street, I've got my buddy next to me. She has lived experience. She's incredible. And she connects with the patients in a way I never will be able to. And that's our community right there. That's it. It's team times 2, right? We have our syringe services program. We change out pipes. We do whatever somebody needs, but here's your treatment team and we've got you. It can be that simple. And then culture of harm reduction. I just mentioned, here's needles, here's safe pipes. Can I get you some condoms? Would you like some fentanyl test strips? Harm reduction is a huge part of what we do, because if my patients continue to die, I can't get them into treatment. And I haven't figured out how to make this in less stigmatizing language either, but I saw a poster that said dead addicts don't recover. And I will not use that term in my, except in my teaching and speaking, but that's so true. If I lose my patients, they never get a chance. And so, oh, yeah, dead patients don't recover. Yeah, you can't. If we lose them, we've lost. And so that's why I thank my patients when they come in and see me. I know many times when they relapse, they're very ashamed. They feel so much shame and self-stigma. They'll come to me in tears. I'm like, no, 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 you're alive and you're here. That's it. That's all I need to get you into care. So, all right. So we're going to talk specifically about this low barrier treatment. And this applies to fentanyl. Like I said, I do this all the time. From the ER, and again, I'm an ER doc, right? So from the ER, it was, oh, this is the addiction treatment providers. This is somebody else's problem. Why can't somebody else do this? This is a 4-alarm fire, okay? Overdose patients have such a high risk of death, not even if they've survived that overdose in the next 1 to 2 days, much more so than many of the other things that we freak out about as ER docs. Right? You've got your heart attacks, you've got your stroke. My overdose patients are more likely to die than both. So taking that back to your providers and kind of putting it in the brain, this is an emergency and we need to act. And then if you look at some of the other information behind this, if we don't have a patient in treatment, okay, they have a 6-fold risk of death. Okay, just kind of broadly, okay? If you get them into treatment, you bring that much, much, much closer to the baseline death rate of the general population. That's why we do this, right? And I know Dr. Coffin mentioned earlier, you know, if someone is using both methamphetamines and fentanyl, there is a higher risk of death. You have a risk of infections, you know, heart infections even. There is risky behavior associated with any substance use, but you can definitely, by getting someone into treatment, keep them alive to continue their care. All right. So jumping forward, we already talked about this. All right. So there are 3 main medication types to treat opiate use disorder. Okay. Well, I'm going to briefly hit 2, and then we're going to really dive into buprenorphine. So I showed you my little receptor, right? Methadone is a full agonist. Okay. So if you give someone methadone, it binds to that receptor, fully activates it, so you can still have sedation, breathing difficulties, and then overdose. And have I seen patients overdose and die on methadone? 100%. Absolutely, you can overdose and die on methadone. Yes, it's much easier to do so if you add other substances, just like everything else. But because it's a full agonist, it activates that full receptor. Okay. Methadone is obviously very specialized in where it can be given. I cannot use it on the street. And frankly, I wouldn't be comfortable because it has a safety profile I can't use in that situation, okay? So the third class on the other side are our blockers. So they bind that receptor, they knock off, say fentanyl, they bind that receptor and it's inactive. It does not get activated, it cannot be used, okay? So as you can imagine, if the patient's body is used to having fentanyl around, you put something else on that receptor and it's no longer activated, there we get into withdrawal. And so these medications are more preventative, right? You have them there, so a full agonist will not work. This is more long-term care, and again, I can't do this in this situation. Buprenorphine, I don't know how we got so lucky to have a medication that works this well and has this kind of a safety profile, but I will not fight it because it's an amazing medication. It comes in multiple forms. In my training, buprenorphine didn't exist. When I got to my hospital, we had an addiction specialist that taught me how to use it. He taught me to use it IV. So the first probably 15 years, I used Bup essentially only IV. So you can use an IV formulation. There's tablets, films, right? There's patches, the whole schmack. You can give it as an injection. Very versatile. All right. This is why I love this medication. Okay. And I already told you there's no disclosures. I just love that it keeps my patients alive. The antagonist, right? So you get that mu opioid effect, all those opiate effects I mentioned with the receptors. The antagonist, your naloxone, your naltrexone, no effect. They block it all, okay? The full agonist, my morphine, my heroin, fentanyl, it continues to go up as you get more drug in your system. Buprenorphine has this crazy ceiling effect. And I think it might have been a mistake, but I'll take it, that they did a study and they found that patients got 96 milligrams of buprenorphine. The normal dose at the time was about 4 to 8, and they had no ill effects. So it's about 10 times the normal dose. How many drugs can you do that with? Like, that's just nuts. No ill effects. And overdosing on bup in isolation is pretty darn near impossible. I would believe it's case reportable. Okay, you can mix it with a bunch of things, and as Dr. Coffin was talking about this morning, the polypharmacy, that's a different circumstance. But Bupe by itself is so incredibly safe, and that's the reason I can use it on the street with patients that have no access to even what many of us take as our normal luxuries of a safe place to sleep in a toilet. Okay, so medicine's funny. So we lose our beans about giving aspirin to our heart attack patients. You have to give them aspirin. You got to save their lives. You got to give them aspirin. Okay. Well, if you give aspirin to a patient with a heart attack, you have to give 42 people with a heart attack an aspirin to save a life. Okay, it's not so bad. Aspirin's cheap. It's easy. A few side effects. All right, I can go with that. And if you throw down here, so these are some of the medications we use to prevent strokes. We prevent treatment failures in pulmonary disease, right? If you defibrillate somebody, you're clear with a cardiac arrest, right? So to start someone on buprenorphine at 1 month to keep them in treatment, you treat 2 patients to keep 1 in treatment at a month. Right there, you're saving a life, right? Because as I showed you before, that 8-fold death rate goes down to almost what it is in the population that is not substance exposed. Okay, so realizing that and I tell my patients, I'm like, okay, I've treated 10 people today, we've saved 5 lives. I mean, we tease about it. It's like, oh my gosh, what you can do. So keeping that in mind. And another amazing person in this work is Gail D'Onofrio, and she published this. It's out of Yale. And they looked at it. So how they did this is they had usual care, right? You come in with a substance use disorder, you get some flyers, some handouts, and good luck, Sparky, right? And then the next tier up was you come in, they screen you for a substance use disorder. They do a screening, brief intervention, or referral to treatment. So they talk to you about it, see if you'd like to get some treatment, and then they refer you to a program, right? Versus just here's a flyer. The third thing they did, however, was do all of that from tier 2, but they gave you buprenorphine. And if they gave you buprenorphine, you had double the rate of success into treatment. Right there on scene in the ER, let's go get your first dose of meds. Okay, so thank you to Dr. D'Onofrio. All right, so this is really interesting. There is still a giant barrier. And if you want to see me get on fire, this is part of it. So I'll kind of try to maintain my frontal lobe right now, but the X waiver. Okay, as of right now, see, I can't, any provider in a hospital or an acute care setting can dose a person on buprenorphine. Okay, like I said, in the D'Onofrio study, they dosed him in the ER. But in order to write a prescription for buprenorphine, I personally, because I did it years ago, I personally had to go through an 8-hour training because I have my medical degree, the MD. For my nurse practitioners and PAs, they had to do 24 hours of training to be able to write for medication that saves lives at the level we just discussed. Did I have to go through any training to write for Dilaudid? How about fentanyl? No, none of it? Nothing. Do I have to get a left ankle fracture certificate in order to treat patients with left ankle fractures? No. And that's why I say I get really on fire about this, because you want to talk stigma and discrimination. Make a doctor or a provider have to have a special training and certificate to treat those patients. This gets back to my stigma talk, and I'm a little on fire about it. That said, they took away that 8-hour training for physicians and 24 hours for PAs and NPs. And now you still have to go onto the website and click a bunch of boxes to prove that you're going to be worthy of giving those patients this medication. Infuriates me. We're working on it on a legislative level, but this still exists as of freaking right now. Oh, you bet. I had to do, thank you for reminding me. I have more fire. I literally, when you go on the first time, you can be authorized to treat 30 of those patients, right? I had to go in and fill out a whole other pile of paperwork to be able to treat 275. Oh, thank you for allowing me. Yep, exactly.
Or they have to go to another level of training.
Yep.
Standard like primary care panels, like 1,000, 1,500.
Yeah, but you can only have 30. Right. Yeah. And so this barrier is just unreal. That said, what the bridge tried to do is to actually make it as easy as possible for the 5 clicks, and then also to actually train docs on how to use buprenorphine safely. So if you want to QR code it or go to the website later or point your doctors in providers in that direction, that's great. But this is really, here's the 5 clicks. It even has them highlighted. You know, you walk through it. Here are the clicks on how to get this special waiver. And then here's how to actually use it to treat patients and to get them good care. So we're trying to break down the big barrier, which is the X waiver, in my opinion, completely. But the small barrier is, let's at least, yes, you have to jump through the hoops of fire, but let's kind of, you know, put a little fire protective bubble around you and get you through it. So that's what we're trying to do in the meantime until we can actually make the change that, in my opinion, is very appropriate. Okay, this guideline is little tiny print, so ignore it, but it's on the Bridge website. You can pull it, I pull it up on Shift whenever I, you know, in the ER, just pull it up. It's so much easier. But this walks people through it, and we just updated it for Bup. I'm sorry, for Bup and fentanyl. Okay, so we had to change the dosing, we had to change the timing because it had to happen. And so this has just been updated. But how you initiate it is when you're going to start buprenorphine, either on the street, and we're going to talk about that specifically, but in an emergency or an acute care setting, if you're going to start it, you need someone in withdrawal. Okay, I mentioned all those receptors. If fentanyl is still on the receptor and buprenorphine comes along and pulls off the fentanyl and binds it, it only partly activates that receptor and the patient will be in withdrawal. So we will talk more about that specifically, but you need patients in withdrawal. And what we used to do, and what I was doing even a couple of years ago, is I would say to patients, are you sick enough? You ready to start? Let's do it, right? I didn't calculate the cows. I was like, the patient knows. And they do, right? Because of that pool of fentanyl that lives in the system when it's been building up that we talked about, it's harder. And it genuinely is. And I tell this to my patients. And so what we ask in doing this, and you can pull this up on MD Calc, it's super easy. But what we ask, and I say this to my patients, because I do street starts, I don't do hospital starts right now, is I need a firm sign, like you need to have something telling your body those receptors are open and ready for buprenorphine. Not that you're going to pull the fentanyl off of them and make you feel worse. Okay, so the goosebumps, the dilated pupils, maybe some vomiting, yawning, tearing, those are hard signs that I ask my patients to look for. Or in the acute care setting, you see them and you see the patients are yawning, they're tearing. It's not the agitation necessarily, because my patients are mainly agitated because of meth, right? It's the co-ingestion. A lot of my patients, and we talk about this all the time, the thought that, well, maybe the meth will smooth out my opiate withdrawal, right? So we have to talk about that. So just feeling agitated or even a little bit flushed or having rapid heart rate may not be opiate withdrawal. That may actually be the stimulant that's on board, or even alcohol withdrawal, right? So kind of keeping that in mind, and that's why this partnership is so important. But I ask my patients, I used to talk to my patients about waiting 6, maybe 12 hours for heroin, right? Pretty generous on the 12 there. I talk to my patients about 24. If you can go 36, that's going to be better. If we can get you to almost 48, we're golden. They're willing to do it because honestly, living in how their lives are lost to this dependency and addiction, they can do it. And they need support. Yeah, the question was about microdosing. We've been trying to figure out the microdosing versus macrodosing in various situations, right? And some people do, they'll put on a patch and then they'll try, as some of those receptors may come open, they put a little more, a little more, a little more. That is absolutely a method. And if your providers are finding success with it, totally an option. And we actually have a microdosing protocol that we talk about as well. I can't get that to work in my situation. In the ER, no time, can't do it. And on the street, can't do it. So this is really an easier for my population, but if something's working for another population, I will not, it's kind of like I say to my patients, whatever works for you is all that matters. Yeah, definitely. Thank you for bringing that up though. Definitely. Okay. So, and we use sometimes what we call kind of comfort packs. Some patients are really concerned about being really nauseated while they go into withdrawal. We can treat nausea. We know how to do that. Some people just kind of that muscle ache, like fluey feeling. That's Tylenol or ibuprofen if it's not ill-advised for that patient to take it. So you can do some comfort meds, as we call it, kind of smooth it a little. A lot of my patients actually use some gabapentin to kind of smooth it a little bit because withdrawal stinks so bad. So there's a lot of ways you can partner with this to do it. And those are other options. But what I asked my patients, and I did this yesterday, my patient used about 15 minutes before he saw me. And I told him, I said, okay, so if we're starting the clock at 11 o'clock on Wednesday, my perfect world, we're talking that we start this 11 o'clock on Friday. Perfect isn't always an option. So maybe 11 o'clock Thursday night, maybe depending on how you're feeling. And if there's these other signs, you'll be ready. Most of my patients have done starts on various times. Either they've used buprenorphine they purchased on the street or have tried a friend's dose or something. So they have familiarity with it. And so that's how I ask my patients to do it. Okay. So let's keep running. So I used to, even a few years ago, we would start with either 4 or 8 milligrams of buprenorphine, not for fentanyl. You need the bigger doses. So I tell my patients, I'm going to give you the 8s, okay? And I need you to take 2 the minute you're ready to go. And then I need you to have the rest with you, okay? So I start with 16 milligrams as my first dose. And so there are a couple of things, and literally I have it on my paperwork to ask every patient every time, that if you're going to do a start, before we do that, there's a couple of things we got to run through. And methadone is one of them. So because methadone's a full agonist and it stays in the body for so long, I tell my patients that I actually cannot, in the emergency or in the street setting, switch them from methadone to buprenorphine. I can't. And so I have to share that information with them. And most of them understand that very clearly. And I ask, any methadone in anything you may have taken, right? Because on the street, if you're sick with withdrawal, you'll take methadone. You bet, if somebody gives it to you, 100%. So I just ask from any source, okay? And then this was another conversation I had yesterday. It was a busy day in clinic. Other substances make an induction on buprenorphine harder in that it makes the picture a little less clear, okay? It's not an overdose risk. You're way more likely to die from the fent and the meth and whatever else you're taking than my bupe and anything else that's in your system, but it does make it a little harder. And so I mentioned I tell these stories to my patients. So I had a patient a few months ago that wanted to get on bupe. So we talked about how to do it. I gave him that timeline, 11 o'clock, whatever the timeline was, and he was scared. And so he used some fentanyl. He believed that if he used meth with his fentanyl, it would make the transition easier. And so he used a fair amount of meth, and then he took a huge dose of buprenorphine. And he was sick as dirt. And he ended up in my ER, and he got a bunch of meds from the ER doc that was on, and he ended up in the ICU. He survived. He 100% survived. But I tell my patients that story. So the cleanest way is if it's only fent, only to bupe. That's an ideal world. We don't live in an ideal world. If it's fent and possibly real Xanax and alcohol and meth, if you can just not add anything extra or anything new to the system right now, maybe as little as possible additional right now, that's better. But still, they're safer with bupe plus than fent plus, all the same. Okay. But those are things I talk to my patients about. And I would ask that you mention when you're talking to patients about this. And methadone's a hard no. Yeah. And so I tell my patients, we actually tried this in the ER. Did not go well. Patient desperately wanted to go from methadone to bupe. And so we tried it. Right. And we did methadone. We did a huge dose of Narcan. And then we did a huge dose of bupe, and it was awful. Yeah. It was totally awful. He absolutely wanted it. It was this, okay, this may not work. This may be terrible. And it was. So I tell my patients that. I'm like, the only reason I ask about methadone is because I'm going to make you feel so bad, you will never talk to me again. I'm like, oh, okay. So always just keeping it honest and clear with the patients is what I find to be the most helpful. Okay. So I mentioned, I tell somebody, you're sick. We've waited for hard signs. Take 16, keep the rest with you. I tell them if in the next 30 minutes, who does time in the, I mean, come on, it's like waiting 5 minutes to give a second dose of Narcan, right? I tell my patients, do the best you can. within about 30 minutes to an hour is kind of the recommendation. If you're not markedly better, I need you to take 8 or 16 more. Okay, I need your butt. What I tell them is these opiate receptors are open. You've gotten yourself in withdrawal, your opiate receptors are open. Throw all the buprenorphine on them you can, because that's how we're going to make you not feel sick and we're going to get you induced on this medication. So literally, my patients do the 32 milligram start, and that's kind of our standard. Okay. If they're pretty much better, I still try to get them to take another dose, kind of get all those receptors involved, right? And that's the way we can get them moving. Don't be afraid to repeat the dose. Like I said, I go up to 32 pretty quickly and without even a concern. Okay. If after an hour the patient's not feeling markedly better, you may want to consider, is it something else? And so there are other things that can mimic withdrawal, diabetes emergencies, sepsis or infectious emergencies. So consider that. But most likely it's undertreated withdrawal if the patient's not feeling significantly better. Okay, so you may need to give more bupe as we were talking about. So we'll start going kind of quick. This is to remind me that everybody talks about precipitated withdrawal, right? That's what's on the street. That's what the providers are talking about. Oh my gosh, precipitated withdrawal. So they measured it, and real live precipitated withdrawal happens less than 1% of cases, less than 1%. The vast majority of times that patients don't feel markedly better with bupe, it's undertreated withdrawal. And the treatment for that is more bupe. And why do people freak out about precipitated withdrawal? Because it's miserable, right? Patients talk about it, providers talk about it, it's horrible. Withdrawal itself is tough, like in general. And so that's something I say to my patients, and this was actually from Dr. Trotsky, sir, who's another genius in addiction treatment, is we're going to make this the best withdrawal you've ever dealt with. And I tell my patients, withdrawal sucks. This is going to suck. But in a week, we're going to be in a totally different place. And they are. So kind of read these over. They'll be in the slides as they come out, just kind of some ideas of how to approach this with your patients. So if you do precipitate withdrawal, right, if it does happen, you're that 1%, what's the treatment? Bupe. Those receptors are still open. You need to give more bupe. And it's hard. The patients are like, whoa, I got that medicine. I don't feel better. And you want me to take more of that medicine? Yes. And I show them my little receptor arm. And I say, you need to get all of those receptors covered in buprenorphine or I can't make you feel better. You've got to trust me on this. We've got to work together. And they do. So just that open and honesty is going to get you where you need to go. So bupe, and more bupe. Yeah.
I don't know, I'm just crazy and I am not a physician, but it seems like the fentanyl to bupe is way different than like other opiates. And doesn't, like even like Sublocade on board and extra strips, they're still struggling with craving sometimes. And I don't think they're making it up. Like,
no, they're not. I agree with you. What are you? Oh, yeah. So we were talking about that even with big doses of buprenorphine or Sublocade, patients are not having all of their symptoms treated, right? Absolutely. And I talk to my patients about that. I go up to 4 strips a day and I tell my patients, I empower them. I'm like, if you need 2 in the morning, half in the afternoon, 1.5 in the evening, 1 in the morning, 3 in the evening, whatever you need to best control your cravings. So I go up on the dose and I give them the flexibility to use it how they need it. And I have yet to have a patient on 4 strips a day not have significant improvement. So, and then it's time. I've had patients tell me after several weeks of, oh my gosh, the first month was hard, doc, but you know what? I'm starting like food. I can taste it again. I feel better. And so it sometimes takes that time. Yeah.
Big thing for me is always making sure that the patient is taking the medication correctly.
That's exactly where I was headed. That's exactly it. Yep. So bupe doesn't taste good and the pills are really slow to dissolve. And so I tell my patients that any part of that medicine that ends up in your stomach, even swallowing your own saliva, your own spit, is wasted, right? You need every part of that. And I do this little gesture. I'm like, you need every part of that absorbed right from that soft tissue under your tongue. That's what's going to get into those receptors. If it gets in your stomach, you've thrown it away. And so what we found for some of our patients that, oh my gosh, I took 16, I feel awful. I'm like, how'd you take it? And they may have vomited. Somehow they didn't get that medicine. So I just start over in those patients. Thank you. Yeah, that's where we're headed.
Swallow the saliva while it's dissolving. I've even had ER docs who were prescribing Subutex and they were telling them patients.
Yeah. You get a tiny little bit. Yeah. And so that's part of the education when you're partnering with the patient, is to tell them how to take it. You know, my teammate with lived experience, she's like, don't eat or drink anything for 20 minutes, even a half hour if you can wait. Otherwise, you're going to lose some of your dose. Yep. Okay. So if you do precipitate withdrawal, you give more bup, as I mentioned. We have teammates. These are 24/7 hotlines for providers to call if somebody in the ER is like, oh, I don't know how to do this. I did it myself, and called and asked for help. So there's support there for your providers if they feel kind of sketchy about any of this. And then we'll kind of run through this. So you have the guideline. It's available. All of this is on there. And on the far side, it shows those resources in addition. And this goes back to my patients. And since I've been talking about them the whole time, we'll fly through this. But if my patient's not in withdrawal right now, my gentleman that used 15 minutes before talking to me, it's the same thing. And you just talk them through it. And I give them that hard timeline, having had some bad experiences for patients when they use right after, and sharing with them, yeah, my last patient had a tough time because we didn't let the medication absorb. So use that experience to get them into treatment. There's a self-start guide as well. I hand this out, and on the very bottom of it, it says to call your navigator for help. So if you're a site that has a substance use navigator or a counselor to call, you put it right on there and just hand it to the patient. Okay, last, where am I?
9 minutes for Q&A.
Okay.
But there's some stuff in the chat.
Okay, I'll fly through some of this since I've mentioned it in some form or fashion, but harm reduction. So every day you keep your patient alive, you have that chance to get them further treatment. And so just considering a lot of the harm reduction that is offered, a lot of patients refuse care because of past bad experiences and of being treated horribly by the medical system, and acknowledge that. Okay, that may be just part of it. I'm so sorry you had to go to the hospital. I apologize that I know that was a hard experience. I know how hard it is to talk to healthcare workers about your substance use. Thank you for talking to me, right? Acknowledge that there has been a lot of struggle for these patients. Normalize, I mean, the way I talk about this is the way I talk about this. This is as normal to me as talking about, little kids with asthma, right? So just normalize what you do, align with your patient. Like I said, that partnership, I'm going to help you through this. We've got this. This is your body. Oh my gosh, I say that every shift. This is your body. You're going to do what your body needs. I'm here to help you do that. Okay. And empower them to do what their body needs to get them on this medication. And then ask, is it okay if I ask you about buprenorphine and what you've used before? Is it okay? I mean, respect their autonomy, respect their need for some privacy, and realize that you're in this together. Okay. And so these are some of the things that we kind of, as openers, people ask me, what do I say? And literally, so I'm assuming you've heard about fentanyl. I mean, something as simple as that to open the door to the patient, that you are ready for that conversation. You want to talk to them about it. Okay. And on the bottom, like I said, do you ever use other drugs such as uppers or meth to smooth out or to balance your fentanyl use? I mentioned to you my concern about fentanyl test strips. I love them and I pass them out, but my patients need to know the goods and bads. Okay. Narcan. Oh my gosh. I put Narcan every corner of my community. I have my teachers with Narcan on their lanyards. Their school badge lanyards, snip Narcan to it. We just have to, in my opinion. Never Use Alone is a hotline that if I'm about to use and I don't have any friends or anyone around me, I call this number. I give them some quick demographics. I use my substance. If I stop answering, they call 911. This is a resource for everyone. So please, and this will again be in the slides coming out. We also talk about safe injection, and I try, if my patients are in a place to consider that, if they can switch to smoking or snorting instead of injecting. And even having that conversation lets the patient know that you're ready to meet them wherever they are. And I think that's really important. And obviously Hep C, health screening, that kind of stuff. So here's some access to the bridge sites, and we are to Q&A, and I'm probably like 2 minutes behind. I did it. Thanks.
Okay, perfect. So there's a couple of comments in the chat online. Just want to make sure I get that to you. One was earlier during the discussion about the X waiver And it looks like there's a comment, kind of like a question about, aren't there restrictions that pharmacists are under with regard to the amount of bupe they are ordering and dispensing to?
It depends. I work very closely with a private pharmacy who does not have a corporate ruling, and they have no problem whatsoever getting any buprenorphine for any of my patients in any quantity at any time. So there are some corporate issues. Yes, dear.
So I'm that coordinator and I deal with pharmacies all the time.
Perfect.
Excuse me. One of the things that I can't stand. CVS, Walgreens, Walmart, they all have their own policies and procedures in place when it comes to bupe. CVS a lot of times will have a cap on how many patients they can release bupe to. So if you bring a prescription in on one day, and they'll tell you we can't release anything until the next month. Walgreens will just not release meds at all, period. And Walmart is also the same. So they make their own decision on whether or not they want to release meds, or if they even carry them. So yeah, constant problems.
There's another question. Just one moment. There's another question online. They've just been waiting. So another one from Tiffany Newport is, do you have information on the effects of buprenorphine products on oral health?
Oh yeah, that came up. That came up recently. And there was a concern about buprenorphine and dental issues. And what was interesting is in the community that I live and work in Monterey and the Tri-County area, there was a lot of fire about that. It's like, let me get this straight. Patient may have some dental issues associated with being alive. And it's really that cost benefit ratio that came up when we were talking about it. And so when you look at cost benefit, there absolutely may be, I mean, you think of the millions of doses of buprenorphine that have been used over the time that we've been using it, and this potential dental associated issue. I'm not arguing that it can't happen, but I'm saying we have decided in my community that is a low enough risk compared to the risk that our patients are facing, that we'll talk to the patients about dental health when they're in a better state to accept it. That's a beautiful question. Thank you.
Okay, great. We have one more question and then just one comment really quickly. From Natalie Christensen, I had a situation where a patient didn't have an active ID and a bupe ID was not distributed. We had to go real ID route. However, that still took some time.
So my pharmacies, and this is even my chains that otherwise are resistant, they will fill the buprenorphine if any person with an ID is with that patient. So one of my harm reduction teammates, who unfortunately recently died, he used to take patients to the pharmacy with his ID. So brother, sister, mom, friend, neighbor, doesn't matter. Any ID, any patient can help your patient pick it up.
And then one last question.
So I'm doing a lot of telemed inductions where I don't have the patient in front of me. And then, so they're going from fentanyl to bupe. They end up needing a lot of bupe, and then they need to refill their next prescription. And they've used more than 24 milligrams per day. How do you handle that issue?
If I think it's going to be a rough start, I will give them enough for 4 a day. And most of my patients present to me not ready to start. So if you think about it, if you give them 28 of them, but they can't even start for a day and a half, I usually end up okay. Also, the first few days are the hardest. So I tell my patients, you may need 4 tomorrow and the next day and the next day, but maybe after that it's 3.5. And so the patients are really good at cutting the strips and figuring out how to use them. So that's how I handle it. And for my new starts, I ask my patients to see me in a week. The next time I'm in the street, and I ask them to come back and I tell them, I just need to see you to see how it went to figure out what your next dose is. That's how I handle it. Yeah. Does that help? I hope.
All right. Thanks, everybody. Give one round of applause again.